Good afternoon, everyone. This is Andrea Boucher from MPro. We know we're at the top of the hour right now, but we're going to give everyone just a couple more minutes to log in here really quick. So hang tight with us for just another minute.
Good afternoon.
Hi, good afternoon, everyone. We'll give it just a couple more minutes before we get started. All right, good afternoon, everyone, and welcome to the American Heart Association and MPro's webinar on Target BP. We're really excited to have you join us today. Just a couple of housekeeping items before we get started. I have placed all participants on mute. So if you do have any questions throughout the presentation, feel free to add those in the chat, but we will have some time for Q&A at the end of the session as well. We are joined here today by Dr. Philip Levy, the professor and associate chair for the Research Department of Emergency Medicine and the assistant vice president for translational science and clinical research innovation at Wayne State University. And he will be sharing strategies to get ahead of blood pressure. So following his presentation, we'll provide an overview on Target BP, and you'll be hearing from some staff from the American Heart Association and MPro as well. So to start us off, I would just like everyone to please enter your name and your organization in the chat box so that we can track attendance and make sure that we get you logged in for today. At this time, I will go ahead and turn it over to Dr. Levy.
Hi there, can you guys hear me?
Yep, we can hear you.
All right, great. Just looking for my slides.
I will share controls with you, Dr. Levy, so you can advance your slides.
Okay. And am I getting too much feedback on here, so I switch over to the phone?
You sound great.
Oh, terrific, thank you. I'm a little tired, I'm not feeling so great, but all good.
All right, you should have control. Right. I think you should be all set.
Hold on a second. I'm not seeing the controls here. I apologize for this, guys. I was on another call. Didn't get on here before.
You can probably use the up or the down arrows, or if you click the mouse, it should advance.
There you go. Okay. There you go. Okay, yeah, so we're going to be talking for the next 20 minutes, half hour or so on getting ahead of high blood pressure. And I know that many of us on the call here are involved in care delivery around high blood pressure, and it's probably one of the biggest things that we all deal with in our clinical settings. But I wanted to do a little bit of a review about some aspects of high blood pressure, kind of walk through some ways to optimize blood pressure measurement. And then get into just some basics around hypertension itself. And then, as was stated, there'll be some time for questions afterwards. And I encourage you guys to ask anything you want, whether or not it seems even related or relevant to the presentation I gave. I'm happy to answer any questions related to hypertension. So hold on here. There we go. So there's an opportunity to improve in several areas related to blood pressure itself, hypertension care, how we measure hypertension, how we approach the management of it from both the patient perspective and clinician perspective. But probably the most important thing that we all need to know is that almost half of adults in the US now have high blood pressure, and only half of those patients get to control. And when you look at this, a lot of this understanding has evolved over the last couple of years. In 2017, the ACC and American Heart Association, that's the American College of Cardiology and American Heart Association, redid guidelines. And prior to 2017, the gospel, if you will, regarding high blood pressure really had been the JNC7, or the 7th Joint National Commission on Hypertension Management, Diagnosis Management, and the like. And that document was initially published in 2003. There was a follow-up version to it, the JNC8, which came out many years after it was intended to come out, that didn't really achieve consensus and didn't really achieve maybe what it intended to do, which was update and advance the JNC7. And so understanding that, and understanding that we are in a period of kind of advanced understanding of high blood pressure and what it does to the body, the new guidelines came out. And the new guidelines really did what I feel is a service, not a disservice, but a service to patients who suffer from high blood pressure and the population in general, by redefining hypertension as a blood pressure greater than 130/80, whereas JNC7 and historically before that had defined it as greater than 140/90. I think everyone understands or knows this information, but the key point is that by doing so, you increase the prevalence, or the number of people who have hypertension, as you can see here under the JNC7, which is the red portion. About 32% of the population had high blood pressure. With the addition of the lower numbers, you gained about another 14% or so, putting it at almost 46% of the population. When you follow the pathways for management of hypertension according to the guidelines, for pretty much everybody, lifestyle modification is included, and we'll talk about that throughout this discussion. But for the patients who fall between what was not hypertension under JNC7 and became hypertension under the new guidelines, the initial evaluation and management is really surrounded or centered on lifestyle, less so pharmaceuticals. So what you see on the left side here, when it talks about the prevalence and percentage of US with hypertension, what you're really looking at is the number of people who would be diagnosed under that paradigm, but smaller numbers of those individuals would be targeted for pharmacological treatment just because of the emphasis in the beginning stages on lifestyle modification. But perhaps most importantly, on the far right over here, you can see blood pressure above goal pharmacologically, among pharmacologically treated adults. It was lower than 40% if you look at JNC7, and then closer to almost 53% that are above goal. So these are the patients that their blood pressure is not controlled. So you can see as we change the guidelines, the number of people who have hypertension and have hypertension controlled really changes somewhat. And this is just another way to show the numbers side by side, but also to show by groupings. So it's not equitably distributed across ages, sex, or race. And as you can see on the left-hand side here, greater than 130/80 versus the right-hand side, greater than 140/90. You can see that, again, 46 versus 32% of the population, but men slightly more than women. And as you go up in age, the prevalence and the proportion of the population is much higher. And that's because there is just a natural age-related rise in blood pressure that occurs, and a lot of comorbidities that go along with it that can increase blood pressure, like diabetes and accumulated years of smoking and obesity and lack of exercise and the like. It also is not equitably distributed by race and ethnicity. As you can see, whites are, while hypertension is still highly prevalent, less likely to develop hypertension than blacks, and in particular black men. You can see in black men it's almost 60% versus 42% or so with the old criterion. So it really is affecting a lot of people, and lest anyone has any confusion on this, the single most important contributor to cardiovascular disease risk worldwide is hypertension, high blood pressure. And so it's really important that this is just on our minds all the time. when you look at what proportion of the US population who has hypertension should be medicated, again, based on those guidelines, or should start with pharmaceuticals, you can see that it also is not equally distributed, that younger people will tend to have lower blood pressures. And so they may fall into that 130 to 40 group where lifestyle modification is the primary intervention. But as you go a little bit further on, you're going to start to see above the age of 65, 55, 65, you're going to be getting more than half to almost everybody who's got hypertension falling into the bin where recommendations are for antihypertensive medication early on. And, you know, to make it clear, even in patients for whom lifestyle modifications are where you start, if you don't get blood pressure control, then the next step within 3, maybe up to 6 months, depending on how things are progressing, within short order, the goal is to get patients on antihypertensive medications so that you can drive blood pressure down. Now, I mentioned the word consensus before, and it's important to understand that there is probably as much a lack of consensus as there is consensus, in the sense that the ACC/AHA guidelines, which were published in 2017, are agreed upon in general by most clinicians in the States, but not all clinicians. Some clinicians still feel that you might want lower blood pressure targets for some patients versus others. As we know, the definition of hypertension is 130/80, but it also depends on how you measure that blood pressure. So typical office or clinic-based measurements, the blood pressure is 130/80. The European Society of Cardiology and European Society of Hypertension actually adhere to the older numbers of 140/90. Now, if you look at daytime measurement, nighttime measurement through home blood pressure monitoring, you can see that the numbers are a little bit different. We all know that patients, their blood pressures will go down at nighttime. That dipping at nighttime is a common phenomenon. It's your body's natural reaction to sort of winding down at the end of the day. If you don't dip at nighttime, that's an indicator that you may have some long-term problems controlling blood pressure, because perhaps your internal homeostatic monitor has reset. There are other reasons that go into that. But again, you can see the Europeans have slightly higher numbers compared to the States. And if you do 24-hour blood pressure monitoring versus mean blood pressure monitoring at home, the numbers are different. And also, like I said, one of the important things is that the BP target in the States is set at 130/80 for all. In Europe, they're really targeting systolic a little bit more than diastolic, and they're targeting 140 and close to 130, but not below 130. And I think the bottom line with this is just to know that there are differences. We are in the US, and so the guidelines in the US are the ones that we all should be emphasizing. And the reason that they went this way is just really understanding that blood pressure itself is not a threshold-based condition. It's not like you hit some number, 130/80 or 140/90, and that's when things begin to go bad. What it actually is we're all born with relatively normal blood pressures, unless we have some genetic or another metabolic reason to not have normal blood pressures. And over time, our blood pressure increases throughout life. That increase, if it is more profound than just physiologically normal, it can and does produce ongoing accumulated vascular insults. And it's that accumulated vascular insult, the minor injuries that come from rising blood pressure to nephrons and neurons and cardiomyocytes, that singularly, or 10, 20, 30, 40, 100 cells that get injured, it doesn't make much of a difference. But then when you get a large number of these cells accumulating injury, that's what causes the target organ dysfunction that we're all used to looking for in hypertension as what we call target organ or end organ manifestations of high blood pressure. And the understanding is that while the likelihood of accumulating such small insults increases the higher your blood pressure goes, those insults are being accumulated throughout the process. And so if we only wait until blood pressure hits a higher threshold, we're going to miss the opportunity to prevent ongoing organ damage over time. And so that's really a primary impetus for changing the blood pressure targets. So important to recognize, but again, 130/80 is a number we should all be thinking about. Now, that measurement, as you saw in that prior graphic, how you measure blood pressure, where you measure blood pressure is really important because there are diagnostic criterion attached to that. But what we also know is that where you measure it and how you measure it is not always the same, and it's not always accurate depending on how it's done. Anybody who's tried to take their blood pressure at home knows that it's kind of challenging to put a cuff on your arm by yourself. Imagine doing that with rheumatoid arthritis or some other dexterity limitation. Imagine doing it in a way that you think you know what you're doing, but you've never been formally trained and you're expected to do it. And likewise, we expect a lot of our clinicians to do this type of stuff, but we know that blood pressure measurement is not really seen as something that everybody thinks they need training in. I think a lot of people presume the first time they do it, they can figure it out. And that may be the case when you're using automated monitors, but when you're talking about manual measurements, it's a little bit difficult. And I think a lot of healthcare providers, as it says here, are confident in their own abilities. Everybody thinks they have the best way to measure blood pressure, particularly if it's manual and that somebody else doesn't quite know how to do it. But in actuality, a lot of us haven't really been retrained on this for a while. There's not consistent training. And the first and last time, as it says here, when they learned how to measure blood pressure was probably the first day or one of the first weeks that they were in their clinical training portion. And so it becomes one of these things where you're taught how to do it. Everybody then assumes they know how to do it. And then going forward, you don't really adjust your skills or sort of retrain how to do it. And that may be because it's not seen as a priority, or because training again for something as simple or perceived to be as simple as blood pressure measurement, it's kind of insulting to some of us. If we've been doing this for quite a long time, do we really need to be trained again and how to do something quite as simple as blood pressure measurement? Well, maybe and maybe not. I think it depends. There are some key considerations that we need to know. It's not just on how you measure the blood pressure as a clinician. It's also how the patient is positioned when you're measuring the blood pressure. So obviously, one of the most important things is that you're not measuring blood pressure when a patient is agitated. I am an emergency physician by training, although I do a lot more population health work now. And one of the things that I see often coming through the emergency department is we'll have triage blood pressures taken on prisoners. We, at Detroit Receiving Hospital where I work, we see, I think the last number I saw was 54% of everybody arrested in the city of Detroit ends up coming through the ER for medical screening. And while that number may have gone down due to some changes in the jail, what I would often see at triage is a nurse taking a blood pressure with a prisoner whose hands are cuffed behind their back and they're agitated. And you can imagine what that number shows. It's obviously not going to be accurate. And so you really want, if possible, to get someone resting quietly, sitting there for 5 minutes alone. You don't want to be in there conversing with them. You don't want to be agitating them in any way. And not that, we're agitators by nature, but just as you start to talk to somebody about their medical conditions, it can get them a little worked up. So best if they're sitting quiet and alone, and they should be seated with their feet and back supported. If they have any muscle exertion that's occurring, they're holding their legs up or they're leaning forward and actively holding their body up, that can increase the blood pressure a little bit. The arm should be bare and supported at the heart level. Oftentimes you see blood pressures being taken with someone whose arm's at their side. It's being taken over a jacket, especially in winter time. Again, I'll see this at triage. We have patients who are wearing some pretty heavy coats, and sometimes we see blood pressures being obtained over a jacket. And then ideally, you're not taking any single measurement. You should be taking a couple of measurements and taking the average of that. And that's difficult, right? We know that it's difficult to do, particularly manually, but it's difficult to do when you're in a high throughput setting, like an emergency department. You have a number of people that you have to triage, or you're in an office setting and you have a high volume of patients. It's not that easy to do this and to sit there as a nurse or somebody who's a med tech helping the process. And one of the other things that we often don't think about, or maybe we think about it, but after it's a little bit too late, is using the appropriate size blood pressure cuff. So as you can see, we should, at least in theory, be measuring arm circumference and then targeting the cuff size based on the arm circumference. Now, I think a lot of us can sort of visualize who really needs an adult cuff versus a large adult cuff, or even an adult thigh cuff. We can probably picture patients in our minds who have 50 centimeter plus arm that we may not have the adult thigh cuff ready or available. So it's really important that we do use the appropriate size cuffs. And as you can see in the preceding picture, I'm going to flip back for 1 second here. It should be above the elbow, and it should be, over the brachial musculature, and not on the forearm. I'll see people doing that every once in a while if they don't have the appropriate size cuff, measuring over the forearm, and that really is not ideal. And importantly, doctors, even though this picture shows this, and this is from PubMed, one of their clinical guidance documents, it's not really a thing that doctors should be doing. And some of that has to do with the fact that we don't really take these blood pressures very often anymore. And there's nothing magical about a doctor versus someone else who does this on a much more frequent basis. So in general, we discourage our physicians from being the ones who take blood pressures. And sometimes there's even a bias in there. You want a number to be where you want it to be. You don't trust whoever else took that number, and so you measure it, and you get kind of what you're expecting. And important to keep in mind too, if you do it manually, you're relying on sort of your hearing to understand what the measurements are, and sometimes you're looking at the mercury in the sphygmomanometer to tell you kind of where those little notches may occur when blood pressure starts to pick up after you release the cuff. And that really is just not the ideal way to do things. And so in general, it's best if somebody who is not directly related to the patient, is not the clinician, is doing this. Doctors are more likely than nurses and med techs to induce a little bit of an artificial elevation in blood pressure as well, because there is some nervousness about the interaction on the part of patients, and also some concerns about sort of the conversation that may be occurring at the same time related to why the patient's in the office and what problems they have. So what devices are we using? Well, the auscultatory methods are the traditional methods to use. We have all, I'm sure all of us have seen these methods, used these methods over time. The oscillometric method is what's become more common. It's the automated approach to measuring blood pressure. And in general, the oscillometric method is felt to be more accurate than the auscultatory method because the auscultation, again, requires you to hear and coordinate the visualization between the release of the cuff and the auscultation of the sounds, and that can be challenging. So the oscillometric methods are preferred, but not all oscillometric methods are created equal. And there are now automated office-based blood pressure monitors, or what are termed AOBPs, that can do multiple serial measurements in an unattended manner, that is. And so you see this here. This is the gold standard automated office blood pressure monitor. This is the Omron 907 XL. This has become the gold standard for various reasons, but one of the important things is that this was the instrument used in the SPRINT study, which SPRINT was the trial that compared a blood pressure using the old goal of 140/90 to a more intensive goal of 120/80, and showed clear benefit with 120/80. The guidelines took that information from that, and rather than saying everybody should be less than 120/80, kind of picked the middle ground of 130/80, but nonetheless, the instrument used in the SPRINT trial was the Omron 907 XL. And what it does when you get these measurements is you get a more accurate, more accurate depiction of what the blood pressure is, because it takes the blood pressure and does two unique things. As you can see, there's a big start button, and you can actually push that button, the tech or the nurse push the button, walk out of the room, and then the device takes 3 measurements. You can set it to take more measurements if you want, but in general, it takes 3 measurements. You can discard one of the measurements if you want, but it takes the measurements and takes an average and then gives you the number that you want, not the number you want, excuse me, it gives you the measurement method that you want, which is, the multiple measurements and taking the average. And data that compare the average difference in multiple studies. This is from a meta-analysis of automated office blood pressure monitoring versus traditional office-based monitoring, shows you that on average, the routine blood pressure measurement in the office using a one and done oscillometric method or the auscultatory method is going to be about, the systolic blood pressure, about 14 millimeters of mercury higher. So what this kind of tells you is 2 things. It tells you, one, you can get more accurate blood pressure readings by using these automated office-based blood pressure methods, but also you can get more of your patients to be in the controlled range potentially because you're doing the blood pressure measurement in a more accurate manner. So that's important when you have an ACO and you have responsibilities for getting chronic care management in place and doing things where you're held to metrics around your achievement of ideal or optimal blood pressures in your patient population. So even though it sounds strange or maybe like a gaming approach to the system, it's really not, because what you're actually getting is a more accurate measurement of blood pressure, removing any of the potential falsehoods that come in from the measurement method. And the summation of this article, basically, if you look at the findings from almost 9,300 participants, in the meaning right there, automated office blood pressure measurement should replace recording of blood pressure by nurses and physicians in routine clinical practice. And in doing this, again, we might be able to see improvements in who achieves blood pressure control, because we're actually doing more accurate measurements of blood pressure. So home blood pressure monitoring is another piece of this. Home blood pressure monitoring is something that helps both the patient understand what their numbers are, and that drives or motivates patients to want to do better to get their blood pressure under control. But it's also a good way for clinicians to understand what is occurring with their patient when they measure the blood pressures at home. And as you can see, there are two different devices or different types of devices available. The Omron is just an example of one, but there are many companies that are FDA approved to do blood pressure monitoring. They typically have an easier mechanism, as it shows in the image there of the 1, 2, 3 on the right, of how you apply these cuffs. On the left, you can use forearm-based measurements. The forearm measurements are not typically felt to be as accurate, again, as the brachial measurements, but home blood pressure monitoring is clearly something that is good, and certainly helps both sides of the equation understand their numbers. And lo and behold, it is something that we can agree on both sides of the Atlantic here. Blood pressure at home is recommended across the board. In particular, measuring in the morning and in the evening and the week before, and then bringing the machine in itself. A number of these machines can record these measurements, and having the recorded measurements provided to clinicians can be very, very helpful, as you can imagine, a little more accurate potentially than writing them down. But either way, as long as patients are taking the numbers and bringing the numbers to the clinician, it makes it a lot better to really understand how blood pressure is impacting them at home and how effective antihypertensive therapy is. The reason that both the ACC and AHA guidelines and the ESC and ESH guidelines stress blood pressure monitoring at home is because it really helps facilitate the titration of therapy, be it escalating interventions for lifestyle modification, or when to transition and initiate medication therapy, and when to titrate medication therapy based on those numbers. So I can't underscore enough the importance of home blood pressure monitoring. And in the future, we may be getting away from even using cuff-based devices. The FDA approved the first non-cuff-based blood pressure device last year. A lot of people are not so fond of that approach or that particular methodology. Here's an example of a company known as Sensogram. They produce two different devices, neither of which is FDA approved now, but they are commercially available. SensaScan and SensoRing, which is on the next slide, and I'll show that in a second. Both of them use pulse contour analysis. So basically, when your heart pumps blood and the peripheral arteries expand and contract in response to that pumping blood, they produce a waveform. That produces a waveform, and that waveform can be analyzed to give you a measure of blood pressure. This little device right here that looks like a pulse oximeter actually can give you pulse oximetry, but it can give you a host of other hemodynamic variables, including blood pressure. And the Ring, which is really pretty cool, can give you a continuous measurement of blood pressure. And so you can ultimately, in the future, get to the point where you can understand how much time your patient spends in controlled range, and what this might mean for your ongoing care and management of your patients. It's not that clinicians need minute-to-minute feedback on someone's blood pressure, but if you knew that your patient was spending 10% of their time in their blood pressure control range, or 100% of time in their blood pressure control range, I think you'd it would dramatically impact the way you approach the care. So again, these devices are not FDA approved, but they are available on the market. I'm not advocating for one over the other or anything. We do some research with this company, or we're starting to. To me, I'm more intrigued about what it can mean going forward for clinicians like us participating who really want to ensure we're getting the most accurate information to help manage our patients. And the inaccurate readings, important to notice and say that they're linked to improper blood pressure diagnosis and treatment and higher incidence of cardiovascular disease, because we may underdiagnose hypertension or we may overdiagnose hypertension. And part of this is because healthcare providers don't really think that blood pressures are accurate. They think that anywhere up to a half of blood pressure measurements taken across medical practices are not accurate. And we know this comes up all the time from the emergency department, where people are either in pain or anxiety, or they have all these different circumstances ongoing, and we measure blood pressures. They're typically a little bit higher than you would measure them in other settings. And when we want to refer someone on from the emergency department for an elevated blood pressure, you often get sort of the perspective, well, that blood pressure is kind of meaningless because it was done in the ER. And maybe that's true and maybe it's not, but certainly it's a good signal that someone may have elevated blood pressure. But it also speaks to whether we should be doing different things and approaching this more accurately so that we can help ensure that we get people the care that they need. And again, this goes back to training and refreshers and all those types of things, which we're going to touch base on in a little bit. But really, the consequences of this are twofold. You can have overdiagnosis or overdetection, which is white coat hypertension. Those automated blood pressure monitors in clinics can help with that. So can sending someone home with a blood pressure monitor and seeing what they really have. But we also are starting to recognize that it's not just patients having too high of a blood pressure in response to being in a clinical setting. Patients may actually have falsely low blood pressures in a clinical setting. Maybe they didn't drink enough water for whatever reason, or who knows what might be contributing to their lower blood pressure. But when you measure it at home, it's actually higher. So that's why it's really just not quite as simple as office-based measurement alone. As you can see, these graphics are from the ACC/AHA guideline, and really talk about what to do with this. When there's uncertainty, the most important thing to do is to get those numbers outside of the clinic setting, which can give us a lot more information about whether or not the patient truly has elevated blood pressure and what we should be doing about it. So one of the things we can do, though, is try to enhance the accuracy of our measurements as much as possible. The AHA and the American Medical Association have partnered to create evidence-based e-learning courses on this. It reinforces guideline-recommended techniques, and it simulates proper measurement in a manual or semi-automated or automated device. So you can really learn some of the right approaches to be able to do this. There's a 30-minute e-learning course that can be taken anywhere. Again, it gives staff members, clinicians, confidence in what they're measuring, but more importantly, it gives the individuals, the clinicians who are actually doing something with this information, better confidence that the accuracy of what's being obtained is there, and that we can rely on these numbers. It improves some, it includes some learning tips and talks about how to improve patient care, and you can get CE credits for it. So I encourage everybody to take a look at it. And some of the goals of this are ensuring providers receive standardized training, improving hypertension control rates by enhancing the accuracy of measurement, and improving the diagnosis and treatment by enhancing the accuracy of measurement. And when it's fully incorporated into an overall blood pressure program, you see 10% improvements or so in as little as 6 months. And some of that may just come from increasing the accuracy of the measurement itself. So I can't stress that important enough. Again, accuracy in the diagnosis, but also accuracy in the control. So not just accepting the fact that there is a little bit of measurement error and that may be contributing to why blood pressure is not controlled, saying, yes, this is controlled and we're doing it better. So it's important to know that controlling BP is more than measurement. This is an example of a care pathway done using a logic model, which really talks about quality improvement initiatives and accurate blood pressure measurement. As you can see from evidence-based strategies, the MAP approach, the measure accurately, act rapidly, and partner with patients and communities to get them involved in self-management. That self-management often involves giving them a prescription for a blood pressure cuff, or even providing a blood pressure cuff. At Wayne State, where I work, we do a lot of blood pressure screenings in the community. We partner with the AHA in a lot of those, and oftentimes we come with cartons full of blood pressure cuffs. And just giving out the blood pressure cuff alone to people is such a welcomed. I don't know if gift is the right word, but such a welcome deliverable. We've had patients who are just in tears over getting something that we would all probably think of as simple, but it's a very important part of the equation. But it's not just enough to ensure that the accuracy is measured, that we have to ensure that treatment protocols in place to deal with this, that we're communicating with our patients around all of these types of things, and that we're really targeting sustained action to drive down blood pressure control. I thought this was a really nice sort of paradigm about how we can drive guideline-based care in our clinical settings, and really looking at a total time of about 25 minutes or so that really should be spent across the board with the patient when they come into the clinic. Measurements accurately, as we talked about, it's not going to be a 1-minute measurement because you're going to have to repeat it and take a little bit of time. If it's 5 minutes for them to relax and repeating 3 times, it's going to take a good 7-8 minutes to get that done. Reviewing the medications and making sure that we've reconciled all the medications is important. And the lifestyle review and discussion obviously is critical. We know that we can't change everyone's behavior, but you'd be surprised how often people don't really know what they can do to make a difference. And we don't really know as clinicians what they're willing to do, and that dialogue has to occur. And then important, you guys are probably all aware of this, but the ASCVD risk assessment. So the atherosclerotic risk assessment basically is important in the guidelines in terms of some approaches to who should get initial medication therapy versus not. Those with higher risk of developing atherosclerotic cardiovascular disease within 10 years, those who are 7.5% or above based on that number, should get earlier initiation of antihypertensive therapy. And then all of that can be available before the patient even sees the clinician, so the clinician can focus on the interventions that are needed to address these types of things. We know that there are certain lifestyle modifications that do produce benefit. Not everyone should be on medications, and talking about these types of things with patients may even help get some patients off of medications. I think a lot of people don't understand that a DASH diet or a low sodium diet can improve blood pressure somewhere between 5 and 10 millimeters of mercury in those who are hypertensive. And so talking to people about this, particularly if they're developing side effects or they're not happy with the medications they're taking, talking to them about the lifestyle changes that they may be able to do is important. And it may be able to help them decrease the medications, discontinue certain medications. It's unlikely that they'll get off medication totally, but it's possible. Weight loss combined with these other things can really produce those benefits. And we've been working in this area. My colleague, Lori Buis from University of Michigan, and I have an ongoing study called MyBP, a little take on Michigan BP, but MyBP is also for patients to take some ownership of this. And so we created an app that gives daily reminders about medications and about logging sodium and achieving goals and exercise and giving them direct feedback with their numbers. And that direct feedback around numbers, again, is something that can't be underscored. When people see the progress that they're making, it's kind of like weight loss. People who start to lose weight feel good about it and then want to lose more weight. And people who start to see their blood pressure numbers go down feel good about it and want to continue to do the things to make their blood pressure go down. But we know it involves more than clinical care. So this graphic, many of us have seen it, shows that clinical care is really responsible for only about 20% of overall outcomes, access to care, quality of care. The rest of it are things that often don't fall within the purview or the four walls of our clinical environment. And so while we typically focus on these things that are modifiable risk factors that we as clinicians and patients have some control over, the fixed factors or relatively fixed factors are things that we might not have control over that may be impacting the ability of that patient to get their blood pressure under control. We're in the midst now of trying to develop dashboards. This is a mock-up of a dashboard that we're working on in a pilot study with Henry Ford Health System that is going to use population-level data for social determinants based on a patient's residence, what zip code or census tract they live in. It's going to provide that social determinant information, the risks, to the clinician through the dashboard, so the clinician can know whether or not their patient may have the risks for these social determinants or these hard to modify contributors to this, and at least open up the conversation and get other resources if needed. If you know a patient has challenges with food access, or they have housing insecurity or those types of things, you might not be able to fix the problem there and then as a clinician, but you might be able to get them hooked up with social services and resources. At the very least, you're at least acknowledging that this is part of their care continuum and part of what's going to help them get to where they want to be, or potentially institute a barrier or constitute a barrier that may make it more challenging. And at the end of the day, the most important thing to do, if we want to understand this, is listen to your patients. We've been working through the American Heart Association to conduct community cardiovascular conversations. This one's a little bit more, almost 2 years old at this point. This was a conversation we brought people to our Integrated Biosciences Center at Wayne State to talk to them, to understand what they understand about hypertension and what they think are their own barriers. And at the end of the day, if you make presumptions about what your patient does or does not face as barriers, you're likely to be wrong, because you're often surprised by what people will tell you. So with that, you can go to Achieving Accuracy for BP Measurement through the targetbp.org link and get some more information on this. And I appreciate you guys taking some time and interest in hearing me talk through this, and I'll turn it back over now.
Thank you, Dr. Levy. I think at this time we will open it up for questions, and I know we do have one in the chat already. So let me pull that up really quick. Okay, so a barrier to our primary care practices implementing the new guideline of hypertension diagnosis of 130/80 is the statement that came out by the AAFP not endorsing this. Any comments to bring back to our staff about this?
Yeah, so there are some challenges. The problem with a singular goal is that not everybody has a singular goal. So if you have an older individual, classic example, who you're trying to get them down to 130/80 and they feel dizzy every time their blood pressure drops to that level, that's probably not the right target for that individual. And I think rather than adhering to 130/80 as the singular number that everyone has to get to immediately, the best approach is to try to work with the patient to understand, as they drive down to that number, what are they experiencing? And so we're very interested in developing apps that give feedback from patients. Not that everyone's going to want to use one, but when you take your medications and you take your blood pressure, are you experiencing any side effects? And so having clinicians work with patients, not just to create logs around blood pressure, but also symptoms and side effects, is important. Most people can tolerate a lowering of their blood pressure to that goal of 130/80, but it can't be done abruptly. And for some people, it may take longer to get down there in a safe and effective manner. So I think that's really the lesson, is that outcomes are better when you get to 130/80 or less. But that doesn't mean that outcomes are better for everybody, because if someone gets weak and dizzy and falls and has an intracranial injury because of that, then it's not the right blood pressure for them. So I think we have to always try to personalize the approach to care. And while there are guidelines that tell us where we want to aspire to get to, we should have that conversation with patients to understand how they feel as we work towards those goals.
Great, thank you for answering that question. If anyone else has a question for Dr. Levy, you can feel free to unmute yourself, or you can add a question in the chat box.
Hi, this is Sage. I had the question in the chat. So just as a follow-up question, so if we have a patient who we feel it's acceptable that their blood pressure is 135/82, for example, are we still then documenting them as having a diagnosis of hypertension? Or are we saying you do have hypertension, but you're at goal?
Well, I think what you want to say is, maybe I'll just ask this question back to you. Are they medicated at this point, or this is a new patient who comes in and they're 135/80 82 and you're trying to decide if they have hypertension?
Trying to decide if they have hypertension. They don't currently have a diagnosis.
Yeah, the best way to approach that, honestly, is because it's a clinic-based measurement. And as we talked about, depending on how that clinic measurement was taken, it could be anywhere from, 10 to 14 or so millimeters of mercury on the systolic side, higher than the actual. What you might want to do if there's a concern is have them do 24-hour home blood pressure monitoring, or send them home with a blood pressure cuff and have them check their blood pressure in the morning and at night for a week or two and record those numbers. But I think most important to recognize is that at 135/82, absent any other cardiovascular risk factors, meaning they're not a smoker, they're not a diabetic, they don't have hyperlipidemia, your course of action is going to be lifestyle modification. And depending on what their body mass index is, depending on what their dietary patterns are, there's really no harm at that point in saying, you may have hypertension. We're going to try and confirm this, but the first thing you can do is cut back on salt and stop smoking and get some exercise and do those types of things. Lifestyle modifications are never the wrong answer for anybody with any level of blood pressure, unless they have coronary artery disease and can't tolerate any exertion or anything like that. But suffice to say, it's always the right answer to counsel them on lifestyle modification. And you may find if they cut salt out of their diet, the next time they come back, their blood pressure is going to be 125/75. And whether or not they're quote unquote diagnosed with hypertension is less important than getting them pointed in the right direction to maintain wellness.
Sure. And then when they bring back that log, most of our patients, access to 24-hour blood pressure monitoring is difficult.
Yeah.
And blood pressure cuffs, we're trying to overcome that barrier with this program. But so when we look at their log, we're going to see, some blood pressures that are, jumping around and things like that. Is that then deferred to some clinical judgment there? Like looking at the trends and things like that, or is there a clear guideline on that?
Well, the graphic that I put in there, and I'll see if I can skip back a little bit while we're talking through this. No, they've taken my controls away. Apparently, I'm in timeout right now. So
during the different times of day, I remember that.
Yeah,
when you're
the morning
referring
versus
to.
you'd want to not pull them all together. You'd want to separate the morning time from the evening time because the blood pressure is going to drop at nighttime. So take an average of the morning and an average of the nighttime, and then look and see what you're seeing. If their blood pressure dips down at nighttime, that's what you want to see. If their blood pressure is not dipping down, that's a concern, and it's pretty unlikely that they're going to have a normal blood pressure if they're not showing that dipping pattern. But yeah, separate them out and take the morning average and the evening average, and then see what you get when you look at those, and then make a determination. A lot of it too should include the other factors like family history and the like. And certainly, as you can see with the numbers, their race and ethnicity should play into that somewhat. Not that we're approaching the care differently per se, but just recognizing that the likelihood of a 50-year-old black male coming into the clinic having hypertension is pretty high. And so rather than assuming they don't, it's a little bit safer to presume they do and get them on the track so that next year when they come around, that 135 is not 142.
Okay. All right. Thank you. That's very helpful.
You're welcome. Any other questions coming in?
Since doesn't seem like anyone has another question at this time, I'm going to give you another one. This is Sage again. So one struggle that we have as far as our documentation is that the patient's blood pressure, even if they have normal home blood pressures that they're bringing in a log, our blood pressures in the office are higher or are in hypertensive range. And specifically for our reporting, our documented documented blood pressure in the office is still over 140 over 90, for example. And then as far as our quality scores, that's detrimental. Do you have any insight into that? You know, I wish there was a way that their home blood pressure measurements would count, but historically they haven't. So I was just wondering if there's a way that you've approached that.
Well, I think that's where the automated office blood pressure monitoring can really help out. By using a device that actually can get a more accurate measurement, you are less likely to fall prey to that circumstance, which is very common, right? That the measurement in the office tends to be higher than the measurement at home, and the measurement in the office, if done inaccurately, and I'm not, you know, claiming that you guys are doing it inaccurately, but it just may be by virtue of doing what everyone's always done that you haven't gotten there. And I would be surprised if you guys went and purchased, you know, one of the Omron 907 XLs or a similar type of device. I showed a picture in there as well of the BP True, which was the original variant of this, but unfortunately that company went out of business. But I bet you if you went in that direction, you might see more of those patients who had those, what probably is spurious or inaccurate office-based numbers compared to their home numbers. You would probably see that diminished pretty much for a lot of patients.
Okay.
But you know, whether home-based measures can be incorporated for the quality metrics and for HEDIS measures and that type of thing, that still hasn't taken hold. But as we move towards an era of remote patient monitoring, and more practice settings are going to be looking at remote patient monitoring, you know, perhaps primarily because there's billing codes attached to it, but also because it can improve patient care. That is really, I think, where we're going to need to go. We're going to need to understand that reliance on office-based measurements is not giving us the full picture, and to deem a practice that, you know, to say a practice is not performing at the highest level based on inaccurate information doesn't make a lot of sense.
Right. Thank you.
You're welcome.
Great. Thank you so much for your presentation, Dr. Levy. And I think those were some really great questions. I think at this time, we'll switch over to our discussion on the Target BP program. So again, this is Andrea Boucher. I am a program manager here at MPro. And just wanted to give you briefly an overview of the Target BP program and what the MAP framework entails. So Target BP is a national initiative by the American Heart Association and the American Medical Association. So this is really to address the issue of uncontrolled blood pressure, which we've obviously been talking a lot about today. Target BP helps healthcare organizations and care teams to improve blood pressure control rates using evidence-based quality improvement tools. It also has a recognition component of this program as well for those that are continuing to improve blood pressure control within their practice. So with the MAP framework, which the M in MAP stands for Measure Accurately, as Dr. Levy had already mentioned, we'll dive a little bit deeper into this, but for those of you that will be attending the Michigan Primary Care Association Spring Conference, we'll definitely be providing you a very detailed overview of what the MAP framework is. But for measuring accurately, this portion helps to provide clinicians with a better degree of certainty on on hypertension diagnosis and treatment. So accurate measurement of blood pressure is really important, as Dr. Levy has definitely mentioned, for estimating cardiovascular disease risk and also guiding the management of high blood pressure. With the acting rapidly portion, so this really encompasses what you're doing within your clinic to manage those elevated blood pressure readings as you're seeing them with a specific hypertension protocol that provides the recommended levels on management of blood pressure thresholds. So each of these protocols really starts with lifestyle modification recommendations that includes healthy low sodium diets, physical activity, In some cases, for some patients, medications may be necessary to manage their hypertension, and that's where the patient and provider relationship really comes into play with the next portion of the MAP framework, which is partnering with patients. So this is where the real change comes, when patients take ownership of their own health. By partnering with patients to help remove obstacles to treatment adherence and bring their blood pressure under control, it can really help to save and extend lives. So focus on patients' overall health, including their diet, their sodium intake, physical activity, as I mentioned, also their alcohol consumption and smoking status. So these are just a few ways that you can help to reduce patients' risk of cardiovascular disease. Target BP has a lot of different resources available to you for download. These are both provider and patient facing. So you can see on here a couple of the options for both. So these can be found at targetbp.org. And for the patient facing materials, you can direct your patients to loweryourhbp.org for those publicly available tools and resources for your patients. This slide just shows you a screen capture of the American Heart Association's high blood pressure treatment algorithm. We know that many of you are currently following the JNC8 guidelines. So this hypertension algorithm is based on those guidelines. And what you can see on this resource is the left-hand side outlines the steps that you take for the diagnosis and treatment of hypertension based on what you're seeing for your in-office readings, and the steps that you would need to take until the patient's blood pressure is at goal. The right-hand side of this infographic shows the modifications that patients can make and how much that specific recommendation would impact their blood pressure. So this is one piece of the project for the Empowering Clinicians grant that MPRO can assist you with if you currently do not have a hypertension algorithm in place within your health center, and you choose to use this one. We can definitely help you implement that within your site. And this slide just outlines the guidelines that you're currently following based on the JNC8 guidelines on the different hypertension thresholds. So just wanted to mention that there, that coincides with the previous slide with the hypertension treatment algorithm. And one other component that is really important for hypertension control is making sure that you're practicing team-based care. There's a lot of different things that are happening within your clinic, and it's really important to engage all members of your care team to make sure that hypertension control is a priority in your practice, making sure that everybody is thinking about this and that it's top of their minds, and making sure that you're going to the maximum level of your team's scope of practice, really using your team members effectively and to the best of their abilities. Patients are also key members of their care team and also their families as well. So they really play a key component in their own care. So you should know about community resources that may be available to them that the clinics can provide, because you have a better understanding of what resources might be out in the community that you can provide to your patients as well. So I know I went through that really quickly. We do have a couple of other things we probably wanted to just breeze through really quickly, but we will have this session recorded and the slides will be available to you as well for review. All right. So just to quickly go through this, we wanted to discuss with you all, sorry, this is Elise DeYoung. I've been working with some of you completing your assessments. We wanted to go through kind of some common themes that we've seen while completing the assessments with all of you guys. So for the measure accurately piece, we saw that many clinics are using those semi-automated devices for initial measurements and then manual for confirmatory measurements. There's a lot of variation with the environments described, whether it be that the room can sometimes be quiet, that the patient sometimes has their back supported or feet supported or arms supported, all at the same time, as well as those questions related to what can affect blood pressure around, the use of tobacco, exercise before their blood pressure, or caffeine consumption. So those are some things we saw for the measure accurately piece. For the act rapidly, let's see, there we go, thank you. many clinics describe that there was some type of provider notification for high blood pressure, whether it be the EMR turning a certain color or some verbal notification from the person taking the blood pressure. Andrea had mentioned that there is a specific blood pressure protocol that you all are using. Some clinics were saying that they weren't quite sure about which protocol, so that is something that we would definitely work with you all on to either identify that or implement one. And then there's a lot of room to look at EMR capability and use it to the best of its ability as we continue working together with high blood pressure. And lastly, with partnering with patients, this is one that you all are very strong on. You're well-versed in using collaborative communication with your patients and educating them on lifestyle change. You have some great resources that you're referring your patients to, but also would love more patient education, as we all would. So that's a really great thing with those boxes that we provided to you with those resources that you can hand to patients in both English and Spanish. And then SMBP being a big one, where a lot of clinics are recommending measuring at home, but not able to provide those devices, which is great with this program. So that's something we will also work with you all on. Okay, and I know we are at the top of the hour, so we do want to respect your time. We did have a couple of other slides, but we will make sure that these slides are shared with you today so that you can review them. If you do have any questions, please feel free to reach out to your MPRO or American Heart Association contact. And there is some information at the end of these slides on Target BP registration, so if you do have questions on that process, we can definitely work with you individually on that. So I'll open it up really quickly. If anyone has any last minute questions, feel free to unmute yourself or add it in the chat.
This is Phil, Dr. Levy. I just want to kind of reiterate something you were getting at the end right there, which is to take the automated measurement first and then do the confirmatory with the auscultatory method. And, I just want to caution people on that approach because, like I said, there may be some potential for bias in there. There may be some potential to have numbers be where you want them to be. I often joke with one of the nurses that I work with in the ER, and he knows exactly who he is, that he is the miraculous cure for hypertension, because when he goes to remeasure an elevated blood pressure, it seems to come back normal. And I'm not saying anybody here is doing anything like that, but just keep that in mind that there's a lot of human error that can occur there, whether it's intentional or unintentional bias. And really the most important thing is to set the stage for the patient to have an accurate blood pressure measured by having their feet on the ground, having their back supported, and really striving towards those automated office blood pressure measurements.
Great, thank you, Dr. Levy. I think we'll go ahead and wrap up for today. We will be sending out the recording of this presentation, and we also have an evaluation for you to fill out. If you can please provide us with your feedback, we would really greatly appreciate it. That will be sent to you via email. I hope everyone has a great rest of their day. Thank you so much for joining us.
Thanks, take care, guys.